Hi, welcome to another episode of Talking with Docs. I am Dr. Paul Zalzal.
I'm Dr. Brad Wiening.
And today's episode is on total hip replacement surgery.
One of my favorite operations.
You know what? I think it's a lot of people's favorite operations because if you look at all the different kinds of operations that surgeons do, total hip replacement is one of the best in terms of getting people back to their function and getting them out of pain.
Yeah, changes lives for sure.
So we were going to start with discussing what is a total hip replacement.
Okay. So I guess even a little bit before that, who gets one? Why do people get it? The main reasons would be arthritis, so that could be osteoarthritis or rheumatoid arthritis or post-traumatic arthritis, probably are the top reasons.
Sure. You might have even heard or had a hip replacement for fracture. If you break your hip, that's another indication to have your hip replaced. Often that's a half a hip replacement or a hemiarthroplasty, but sometimes you can get a total hip replacement for certain types of hip fractures.
You can get more information from that on our hip fracture video.
Yeah, absolutely. So what is a total hip replacement? Well, a total hip replacement, similar to a total knee replacement, is poorly labeled. It's not a total hip replacement. I mean, a hip is made up of the bones, cartilage, muscle, tendons, ligaments. We don't replace all of that when we do a hip replacement. Basically, we have a femoral component, which is like a stem that goes into the femur with a ball on the end, and then a socket that goes into the acetabulum or your pelvis, and that makes up your hip replacement. This is an example of a metal on polyethylene one, but you can also have a bearing surface that's made of ceramic on ceramic as well.
Yeah, so when I'm talking to my patients, Paul, this is an example of a hip that still has some of the muscles as half of a hip. You can see deep inside of here is the ball and socket. So the purpose of the surgery is to replace the ball with either a metal ball or a ceramic ball, and then replacing the socket, typically with a metal, some type of metal socket, and then a liner that's either metal or ceramic or polyethylene.
That model reminds me of a good question, Brad. I've been asked before too, do you use a minimally invasive approach when you do your hip replacement, or do you split the muscles, or do you go between muscle, do you cut any muscle, all these kind of questions. How do you address those when you're asked those questions?
So I tell my patients, this is commonly asked too, is that I make an incision, first of all, that's as big as it has to be, but as small as possible. Okay. I don't want to compromise my ability to do the most important part, which is the bony part, by trying to make a really small cut. So in one way, yes, I would say I'm minimally invasive. I think both the literature and industry have used those terms to market themselves a little bit or differentiate themselves, so I think it's complicated for both surgeons and for patients. So I guess we could talk a little bit about the different approaches. Really, I'll talk about my approach, and maybe in some of our other videos we can address the specific differences. I use a direct lateral approach, so yes, after I've cut down through the skin, I divide the muscle and then later on repair it.
Okay, so yeah, we should spend a little more time on another video about approaches. Generally, I agree. As surgeons, we use a minimally invasive approach by nature. We would not dissect anywhere that didn't need to be dissected to get the job done. So yeah, we do use minimally invasive approaches to get the hip in place. All right, so I'm going to have my hip replacement. One thing I have to know before I proceed with my hip replacement are any complications that could happen from this surgery.
Okay, so when I break down complications for my patients, I usually start complications related to the anesthetic, complications that could happen during the procedure, and then complications that could happen afterwards. So I'll talk about anesthesia just kind of generally. So typically when someone has a spinal anesthetic at our institution, our first choice would be a spinal anesthetic where a small needle is placed into your back to freeze your legs. Sometimes that is augmented either with heavy sedation or potentially even a general anesthetic, but that would be our choice. All anesthetics have significant risks that include risk to your airway, to your lungs, to your heart, and those general risks are applied to all operations. So that's probably where my risks and complications start.
Okay, yeah, agree. I have sort of a similar approach. Basically, just tell everyone, this is what could happen. You could have a heart attack, stroke, death, blood clot, infection, pneumonia. Total hips can dislocate. You could have a leg length discrepancy after. I'll talk about that again in a sec, but I tell everybody that we definitely try and minimize the chance of anything bad happening. And the chances of something bad happening are very, very, very small, but you have to be aware that a complication can occur.
Yep. I think the other risk that I tell patients is that because this is a good operation, it's not a perfect operation, there is a possibility that they will either not be 100% satisfied or that they typically would not be completely pain-free. So things like normal, pain-free, are not terms that I typically use when talking about a hip replacement. I tell them it's not going to make them 18 years old again. It's not a time machine, but my goal is to get them as close to perfect as possible.
I agree. So leg length discrepancy. Whenever you have arthritis in a hip, that leg is shortened a little bit because of the wear in the joint. So when we replace your hip, we lengthen it. Sometimes it comes out the same as the other side. Sometimes it comes out a little bit longer. The vast majority of the time people aren't bothered by it, but some people do notice a leg length discrepancy and prefer to put a shoe lift in the other side. They have to.
And there are a bunch of different causes for that. In our leg length discrepancy video, you can see the differences of real and perceived leg length discrepancies. But like Paul said, unless the discrepancy is greater than 2 centimeters, often does not have a significant functional implication. But people will talk about it a lot.
And if you have arthritis in both your hips, often we'll lengthen one side, understanding that when we come to do the other side, we can make your legs equal at that time and make you a little taller, actually.
There you go.
Pick up that basketball.
Excellent.
So another common question is, well, how long am I in the hospital for?
So that certainly varies greatly between centers and between countries. I tell my patients my goal is that you go home on postoperative day number 2 or number 3. Obviously, it's variable depending on the severity of your arthritis, the difficulty of the procedure, other medical problems that you have, your age. The goal is to get people sitting up and walking the very next day. And then I tell people they get to leave when they can take pills to control their pain and they can go up and down some stairs and get around safely on their walker.
Yeah, I agree with that. Okay, so you've had hip replacement, you've been in for a couple of days. What kind of activities am I allowed to do after?
Yeah, so this is common. People say, hey, can I downhill ski? Can I play hockey? Can I run?
Right.
What do you tell them?
Well, I tell people that any time you do any activity with a lot of impact or contact, you're at risk for a fracture. Okay, and if you fracture around a hip replacement, now it's called a periprosthetic fracture, just meaning it's near the prosthesis, and it can be a little bit complicated to treat, but it is treatable. So that's the main thing. You're trying to avoid a periprosthetic fracture, and you're trying to avoid putting your leg or hip in a position that it could dislocate, so turning it out too far or bending it too much. Having said that, I tell people it's okay to ski. You can do downhill skiing. I wouldn't recommend moguls. You mentioned hockey. I don't recommend playing hockey with a hip replacement. However, I do have many patients that do play ice hockey with their hip replacements, and so far, touch wood, I haven't seen any hockey-related total hip complications. And tennis, I tell people, well, yeah, I would let you do as much activities as, say, doubles tennis. But of all the infinite number of activities that people can do, we don't have a lot of evidence at our disposal to say, okay, this is safe, this isn't safe. So common sense basically has to override every decision.
I'd agree with that. I tell people with the types of things you were asking about that they have to decide how important that is to them, because often if something bad is going to happen on the ski slope, probably isn't because you can't ski, it's because an 8-year-old on a snowboarder crossed over the front of your skis and then you fall, which is difficult to predict. But I'd agree with that. The one thing I tell my patients to avoid is repetitive high-impact activity. So if they are a jogger, I tell them to get all of the jogging out of their system before surgery. I don't know why anyone would want to jog. And then after they have a hip replacement, I tell them they're allowed to run either for the bus or from a bear.
Yeah, well, that's from a bear that we see a lot of those around our neighborhood.
Yes.
But I agree. I mean, and the other thing to look at, the other way to look at it is, well, how much activity can you do before your hip replacement? If you're at the point where you're requiring a hip replacement, you're probably not jogging, you're probably not doing a lot of high-impact activities, and hopefully you're not running away from bears.
Yes, and if you are, you probably should wait to have your hip done.
Yeah.
And I tell people before, you can pretty much do whatever you want. The only way you could make it worse is if you broke it. You can't, once your hip's worn out, you can't wear it out anymore, really.
Right. Oh, that's a good point. Where people ask, well, how long will this hip last? What do you tell people?
So there's not a very scientific answer for that. The reason that there isn't one is because the parts that we're using now haven't been around necessarily long enough to predict how long it's going to last. The principle of using a metal ball and a plastic socket, or even a ceramic ball and a ceramic socket, or a metal and metal, have been around for a long time, but the parts we're using are always getting better and better. The short answer for my patients, I tell them approximately 15 years. It certainly could be less. It could be more. Sometimes I see people in follow-up that I didn't do surgery on them, but they've had hip replacements in from the late 70s, and they're still functioning okay sometimes.
Agree, yeah. So, I mean, the plastic should eventually wear, but like Brad said, we can't predict when it's going to wear. But generally, I think we're thinking along the lines of 10 to 20 years now is a conservative estimate, and that's one mode of failure for the hip replacement. Down the road, it could wear, and if it does, then you may need a revision to replace part or all of the implant. There's another mode of failure that's scary. That's infection. Because this is a foreign substance in your body, bacteria can stick to it and you can get an infection. It's very rare, but if it does happen, it's pretty serious.
Yeah, I tell people the risk of an infection is less than 1%. The biggest trouble that I tell my patients, though, is that you don't get 1% infected. Unfortunately, you get 100% infected. And this traditionally is a surgical problem. So some people say, well, can I take some antibiotics? So that would work if you had a superficial infection of, say, your incision right after surgery. But if bacteria get into the hip joint, like Paul had explained, that creates pus and inflammation, and the only way to eradicate that typically is to open up the hip and either wash it out if you were able to get to it relatively quickly, and then potentially you could retain your hip prosthesis. But more commonly, you have to actually take all of the parts out in a staged procedure, and you can refer to one of our infected hip replacement videos to get more details on that. But that certainly is a very big complication, thankfully not very common.
Yeah. I don't want to end our video on a bad note, like infection, but definitely it's rare, but if it does happen, it's treatable, but it is a serious complication. So you have to be careful when you have a hip replacement in place. If you're ever having surgery or dental procedures, you should consider taking antibiotics around that time to prevent an infection. So on a good note, I'm sorry, go ahead.
Oh, I was just going to say that, to not be a negative, that hip replacement patients, I think in my practice in 10 years, are the happiest people who say, hey, you gave me my life back, I can't believe how good I feel. It's a very satisfying procedure as a surgeon.
I agree totally. It's very unusual to find someone who's had their hip replaced and they're not very happy with the outcome. Unlike knee replacements, where some people still have pain, which we go into more detail in our knee replacement video. Hip replacement's a different surgery completely, and the outcomes certainly are very, very good.
So thanks for tuning into this episode. Please feel free to email us at talkingwithdocs@gmail.com.
Yeah, if you have any questions that you wanted us to address in this sort of format, and remember, you are in charge of your own health.
See you next time.